complain about after a rhinoplasty is, Doc, you know what, my nose looks good, but I can't breathe well. So we always think about the inside and the outside, making them both better. So how do we know that there's something going on the inside? We usually can look in with a little speculum, or better, we can pass in a little telescope, which is something with a little light on the end, and it allows us to evaluate the septum in its entirety. It's usually about 3 inches long. We can look at those things called the inferior turbinates, which are due to swelling due to allergy. We can see what the sinuses are looking like. We can look at the adenoids. So we can evaluate the interior of the nose and let the patient know you have a deviated septum, swollen membranes, and while we're doing your rhinoplasty, we're going to fix that as well. Then we discuss the outside of the nose, and it's always important to find out from the patient, what do you dislike on the outside of the nose? It doesn't matter what I like or dislike. I ask them, what do they like? Well, they don't like the little bump on their nose. They don't like the tip of their nose. It's a little bulbous and swollen. It's a little longer than they want. So we first discuss what they like and dislike, and then I tell them what I think are some of the other issues that may need to be addressed, and then we discuss with them how we're going to help them. We'll do the operation. Post-operatively, they'll usually be a little congested. They may be a little bruised externally when they have the rhinoplasty. If they don't have a rhinoplasty and they just have the inside work done for a septum and or the sinuses, there's no facial swelling or bruising. The bruising only comes when we're doing a rhinoplasty because we need to move the nasal bones to realign the nose.
Now, when you examine a patient when they come in and they're, they may not be happy with their nose, but is there a good, can you look at a person's nose and say or anticipate what their real problems are going to be? Or is if a nose is, has a bump, it doesn't necessarily mean it's not working properly.
No. So that's why, the history is important.
Yeah.
Are you congested? Then we like to look in the nose with a speculum or little telescope so that I can tell them the reason you're not breathing well is you have a bump on the outside of the nose. They may have a twisted nose on the outside where the nose is deviated to one side. I can tell them then most probably have a deviated septum, but it's critical that we look on the inside. Sometimes we even want to do an x-ray of the nose, and the best x-ray of the nose is called a CAT scan, not a regular sinus x-ray, but a CAT scan. But we only do the CAT scan usually if they're having facial pain, headaches, or sinus problems. We don't need to do it if they're going to get a rhinoplasty or if they have a deviated septum. More if they're having sinus problems. And many a times we can do sinus surgery at the time that we're doing the rhinoplasty and septoplasty. A lot of patients don't realize that you can do all of that in one sitting under general anesthesia as an outpatient and send them home an hour or two after that surgery.
Another area that you treat is snoring. And I know a lot of patients that have experienced sleep apnea experiences snoring. What do you do for patients who do a lot of snoring?
So once again, ask the patient, do you snore? Yes. Do you stop breathing when you're asleep? Has someone witnessed that? And if they do stop breathing, that's usually sleep apnea. And many of these patients with snoring may, in fact, have sleep apnea. So if you do snore, it's worth seeing your ear, nose, and throat doctor so they can evaluate you, look on the inside of the nose, see if you have a deviated septum. We also look at the inside of your mouth. Do you have big tonsils? Do you have a long swollen uvula, that little thing that hangs down the back of the throat? Because the deviated septum, the uvula, and the tonsils may be the cause for your sleep apnea. So we'll take a history, we'll examine them, we send them for a sleep study. A sleep study evaluates how they're doing at night. It determines whether they're snoring, whether they have sleep apnea, whether they stop breathing for a period of many seconds, what's the oxygen level during the apnea when they stop breathing. So this lets us know whether they have more than just snoring, because snoring is somewhat of a social problem. Is it indeed apnea? And then we decide, is the apnea mild, moderate, or severe? If it's moderate or severe, it needs something more than just treating the nose. They may need something where they put a little bite block in the mouth to hold the tongue forward. They may even need something called a CPAP machine, which a lot of young patients don't like because they've got to put this machine over their nose. It looks like they're on a ventilator at night. Their spouses don't like it. They hate it, and they're going to use it for the rest of their life. But those are the ways that we treat it, either the bite block, the CPAP, or if they don't want that or they've failed that treatment, we can offer them a procedure to help their deviated septum, to remove their tonsils, and to trim that little uvula at the back of their throat. The problem with that surgery in the throat, the tonsils and or the uvula, is it is very uncomfortable for about 7 to 10 days.
Wow.
What do you think about it's over-the-counter, these those strips that goes on the nose, the breathing, the breathe easy strips.
But the strips.
No, the Breathe Right strips are very good, because what they do is they do pull the sidewalls of the nose away. That's why football players, many a time, they're using it. But it's very temporary, and they need to use it every night. Right. Those patients usually have something going on the inside of the nose. But if that works for them, that's fine. If they don't want to do the surgery on the inside, use the Breathe Right strips. But generally, those patients ultimately will come to needing something. Either they have what's called alar valve collapse or deviated septum. And we can address those issues for them, unfortunately, with a surgical procedure if need be.
Now, who's on your team that helps present this to the patient in a way that makes it very not appealing, because nobody really wants to have surgery, but makes it a little bit more palatable? Like, how could you explain, we're just going to stick a small scope up your nose, or, and look, it just sounds to me, and having worked in an ER for a very long time and seen a lot of ENT procedures that are done emergently, I've just always wanted people to stay away from my nose. But who's with you? Is there anybody else on the team in the office that kind of helps with the psychological piece?
It's interesting. Some people do have it. I actually find that it's best if I am there. Sometimes one of my office assistants will help me, but generally it's me that does it. I say to the patient, I'm going to spray in a little decongestant in your nose. I'm going to spray a little local anesthetic. So what I'm going to do is going to be comfortable. All I'm going to do is pass in a tiny little light into your nose. It's not going to hurt, and it will allow me to evaluate the interior of the nose. Yeah. Having done this for 25 plus years, I've never had a patient say, Doc, I'm really concerned about it. They're more concerned when we go further down behind the nose and evaluate the larynx, because those patients may gag. But just looking in the nose is a very simple thing. Now, in children, obviously, they don't like that. So many a time, what we'll do is we'll just use our little otoscope, because they're used to the otoscope going in the ear, and that little otoscope will allow us to look into the child's nose, and that's usually not a problem.
It's a trust issue, too, and I kind of like the idea of not talking to a lot of people about something where I need to totally trust the person that's going to be doing the evaluation. So I kind of understand exactly where you're coming from. I think that works for me. Right. But the children issue, I don't think I would want to work in your office. I'm sorry. I can't even imagine.
Do you see mostly children, or is it adults?
No, I see primarily adults.
Primarily adults.
I am a fellow of the American Academy of Pediatrics, which allows me to see and work on kids. But the bulk of my practice is adults, but I do see children as well.
And for these sinusitis, do you see that it is mostly linked to allergies? Because I see there's
a significant proportion of the patients, in excess of about 30% of the patients, will have allergy. So what allergy does is it swells up those membranes in the nose called the turbinates. It swells up the sinus openings. It may cause nasal polyps. So the management of the allergy patient is critical, in particular before we operate on these people, because we may be able to help them without surgery. And as I've said, even if we do operate on them, they still need allergy management to continue after the surgery. And I engage an allergist as well to work with me. So many of the patients, before I'm going to operate on them, I like an allergist to do the allergy testing. I don't do that. I usually have an allergist do it. Sometimes they need skin testing. They may need management of the allergy in conjunction with what I'm doing medically for them and surgically.
Is there ever a connection, and I think I know the answer to this, but having an expert right here is so nice. Is there a connection with the sinuses then, which you are an expert on, and the ears?
Yeah.
Yes, many of the patients that have sinus problems also have eustachian tube blockage. And what's interesting now is we have a little balloon that we can pass into the eustachian tube and enlarge the eustachian tubes to improve their eustachian tube issue. And the eustachian tube discomfort causes pain, blockage. Sometimes they get fluid buildup. Every time they fly or scuba dive, it becomes an issue. And these little balloons have become a huge aspect of what we actually use to treat sinus patients. Sometimes we can actually, in the office, dilate their sinuses and prevent them from having to go to the operating room and having this endoscopic sinus procedure. We numb them up in the office. We pass these little balloons in, inflate the balloon for about 10 seconds in the involved sinus, take it out, and lo and behold, we can help these patients with a simple office-based procedure in those patients with the more minor sinus problems.
You know, my husband is probably a perfect example of every single thing we've talked about. And he's gone as far as having like tubes put in his ear as an adult. And recently he's had this issue. He blames it on a wide nose. He blames it on his mother. Of course, we blame everything on our genetics. But is it common for someone to have more than one issue? And he definitely ends up with the ear, the congestion and the fluid in his ears, and his hearing loss has been pretty significant because of some of the, the time frames. Like he tries to get it under the 10 days and then he ends up going to the ENT. Is it any of this attributed to hearing loss or loss of smell? Or is there any other losses from this kind of sinus issue? I mean, it's huge, and it's not really talked about that much unless it's bothering you.
It's interesting. Your husband is like so many people. 1 in every 8 patients has either allergies, sinus problems, eustachian tube problems. They may snore. They may have a little bit of sleep apnea. It's all due to things that are usually going on in the nose. May have a deviated septum, may have allergies if he's never been evaluated. His eustachian tube may be a little bit narrower than others. He builds up fluid. It affects his hearing. These are very, very common problems. And as you said, your husband does see an ear, nose, and throat doctor. And these kind of patients definitely need to be evaluated by an ear, nose, and throat doctor, because so much goes on in the nose that causes these multiple problems: snoring, sleep apnea, nasal congestion, hearing problems, eustachian tube, sinus problems. They all go together. And just by looking in the nose with a little simple telescope and sometimes an x-ray like a CAT scan, we can evaluate the problem and treat it. And the good news is with these little balloons that we have today, we can offer the patient relatively simple, safe procedures, and we can help them.
Yeah. Thank you so much. This interview has been so informative for me, even as a nurse practitioner, and I think for the audience, we're walking away with so much information on how we are to look at our congestion and the different surgeries and possibilities for treatment of nasal congestion. So we want to thank you, our guest, Dr. Setzen, for being with us today, and we want to thank you, the listening audience, to your family's health.